Today we're going to talk about intravenous cannulation. It's a skill that you're going to be doing commonly when you're on the wards. The aim of the video is to increase your confidence and proficiency at intravenous cannulation and think about some of the simple things you can do to make the process easier when you're having trouble. For the purposes of time, we're going to focus on the procedure itself, that is setting up and actually performing intravenous cannulation. Obviously, when you do any procedure, you're going to do a timeout, you're going to do a consent process with the patient, and you're going to pay attention to infection control processes. Okay, we're going to start with preparation. We can break preparation down to 3 parts. We're going to think about the equipment that we need, we're going to think about how we place the patient, and we're going to think about how we place ourselves. In terms of the equipment side of things, I generally like to think through the procedure that I'm going to do and picture everything I'm going to need. On the wards, you'll find cannulation kits like these. On the top row, we have things that are provided in the kit. On the bottom row, we have things that we need to add before we commence our cannulation process. In the kit, we have a drape, we have an alcohol wipe, we have some gauze, and we have a dressing. We need to add a tourniquet, a cannula, a bung, and a syringe with normal saline for our flush. The next thing to think about is the patient. During the cannulation process, you want the patient to be comfortable so they're not going to move. If possible, you want them to shuffle over to the far side of the bed to provide yourself with a workspace. Finally, I want to think about my position. I want to make sure that I'm comfortable and that the position is ergonomic. I want to make sure that all my equipment is within arm's reach and it's ready for me to use. So at this stage, we've done a timeout, we've consented the patient, we've thought about our infection control processes, I've made sure that Cam's in a comfortable position, he's shuffled over to the far side of the bed so we have an adequate workspace, I'm in a comfortable position sitting down, we've put a drape underneath his arm, that'll make you popular with the nursing staff, and I have all my equipment in the order I'm going to use it next to the bed. We've found an appropriate vein. I'm going to retighten the tourniquet now. If you keep your fingers underneath the junction, then it stops it from pinching the patient too much. We're going to talk about things we can do to help find veins later. For most cannulation, I just get the patient to squeeze their hand a couple of times to bring the vein up. That's perfect, you can relax now, Ken. Next thing I'm going to do is clean the skin over the vein. The painful part about cannulation is the cannula going through the skin. If you wait for the alcohol to dry, it makes it a lot more comfortable for the patient. Once that's dried, I'm going to take my cannula, which I've selected appropriately. I'm going to tether the skin. Sometimes that can be difficult in the cubital fossa. I'm just going to put traction backwards on the vein like that. In some notes talking about cannulation, they talk about approaching the vein from 45 degrees. I find that angle is too steep. A flatter angle increases the distance between the front and back wall of the vein and decreases the chance that you're going to go through. Once we're ready, I'm going to pop that tension back on the vein. I'm going to come at a very flat angle, advance the cannula in, and now you can see I'm getting flashback. Once I've got flashback, I'm going to drop down so I'm parallel to the vein, and I'm going to advance 1 millimetre further, noting that I've still got flashback. Now that I've done that, without moving the cannula, I'm going to advance the cannula over the front. You can see flashback coming down the cannula barrel there, which means we're still in the vein. At this point, the needle is blocking the cannula, so it's not going to make a mess. That allows me to leave it, undo the tourniquet, and in preparation for any bleeding that does occur, I'm just going to lift that up and pop a little bit of gauze underneath. As you can see, you can leave it for a reasonable period without making a mess. I'm now going to take my bung. To stop the cannula bleeding as I take the needle out, I'm going to occlude the cannula. I'm going to place my fingers over the top and apply pressure down. I'm then going to take the needle out, being careful not to pull out the cannula as I do it. I'm going to pop that straight into the sharps bin. As you can see, there's no bleeding. Now I'm going to pop the bung on. Being careful not to dislodge the cannula, I'm going to flush it. That flushes easily. You can also feel for a bruit at the tip of the cannula. Now that the cannula is in, we need to secure it. There are lots of different ways of securing cannulas. This is just one way, but you need to work out your own method of doing it securely. So I'm going to put 2 steri strips down the side to hold it in plane there, and then we're going to put a Tegaderm dressing over the top. There's a sticker that you can place on the dressing to indicate when you've sited it. You should document the procedure as per the hospital you're working in. We're going to look at methods of troubleshooting common problems. It's important to note that while many of these are straightforward, some of them are more challenging. If you're not comfortable at any point, it's really important that you escalate the situation appropriately. One of the most common problems with cannulation is finding a vein. It's really worth spending a bit of time finding a good vein before you jump into the procedure. Common sites that we use all the time include the dorsum of the hand, the radial side of the wrist, and the cubital fossa. Sites that are often appropriate but used to a lesser extent include the back of the wrist and the upper inside of the arm. And they can present options if you feel that the more common sites aren't appropriate or aren't available. Other sites that you can use include the feet and the saphenous vein. These sites you need to be careful, particularly in people with comorbidities such as diabetes. And it's also really important that you document the cannula appropriately so that it's not left in when patients leave hospital. There are a number of other techniques you can use to try and increase the size of veins. Firstly, you can ask the patient to increase return by squeezing muscles around the vein. Secondly, you can gently tap on the vein. Thirdly, you can utilise gravity, asking the patient to hold their arm or leg below the level of the bed. And finally, you can apply heat to the vein. The easiest way to do this on the ward is to fill a glove with warm water and apply it to the skin, making sure that it's not too hot. Another problem can be movement. This can be the patient itself or the vein. When the patient isn't being cooperative, you can try a couple of initiatives. Firstly, you can get appropriate help from a nurse to try and secure the limb that you're trying to place the cannula in. And secondly, you can try and make it more comfortable for the patient by putting some local anaesthetic in. If the problem relates to the vein itself, tethering is really important.
Good. The administration of local anaesthetic is a simple thing you can do to increase patient comfort. To administer local anaesthetic, you can use a 3mm syringe and the smallest needle that you can find. 1% lignocaine is generally an appropriate local anaesthetic to use. Once you're set up for cannulation, local anaesthetic is administered immediately preceding the cannula itself. That is, once you've prepared the skin and found an appropriate vein. To administer local anaesthetic, you're going to tether the vein as you would normally. Then with the bevel facing down, pop a bleb just under the skin at the administration site. When the vein itself is moving, it's really important to tether appropriately. Tethering is easier in some sites rather than others. In forearm veins, and most other veins in the body, tethering consists of placing gentle traction on the vein to keep it in the right position. The hand is easier to tether. It can be done by flexing at the wrist joint as such.
One problem is when veins blow as you advance the cannula. A couple of tips to try and avoid this problem include picking an appropriately sized cannula. For most of the things that you need cannulas for on the ward, a 22 gauge, which is a blue cannula, or a 20 gauge, which is a pink cannula, will be appropriate. Larger cannulas in inappropriately sized veins can cause the vein to blow. Other approaches include modifying your technique. Firstly, the angle of approach. Many textbooks suggest that you approach a vein at about 45 degrees when placing your cannula. By flattening your cannula out more, you can increase the distance between the front and back wall of the vein, thereby minimising the chance that you advance through the back wall and blow the vein. Finally, when you get flashback, it's really important that you advance the cannula a further millimetre. If you don't do this, it's possible that the tip of the cannula, that is the needle, is in the vein, but the cannula itself, which starts further down the needle, hasn't entered the vein, causing it to kink when it reaches the wall of the vein. When you place a cannula, you get flashback and you can initially advance the cannula, but it then becomes stuck. This is usually because the cannula is up against a valve. There are a few things you can try to remedy this situation. Firstly, you can use the needle as a stylet. To do this, pull the needle back slightly so that the tip is no longer protruding beyond the end of the cannula. Then advance the needle and the cannula together in line of the vein. A second trick is to try and flush the cannula in. Using a syringe filled with normal saline, occlude the cannula, remove the needle and attach the syringe. Gently flush the syringe as you advance the cannula. A third technique is to use a soft-tipped wire. To do this, we occlude the cannula, we remove the needle, and we introduce the wire. If you encounter any resistance, you should stop. Making sure the wire is still protruding from the skin, advance the cannula along the wire. Cannulation can be difficult in some patients, and it's really important that the senior staff support you as you attempt cannulation on these patients. If you've had 2 attempts without success, it's very reasonable to escalate the situation to your registrar. If your registrar cannot then site a cannula, they can call the anaesthetic registrar on call.